Okay, I think we'll go ahead and get started. We have a lot of material to go through here, and today our topic is going to be discussing the Stage 2 Meaningful Use NPR. Some of the guidelines were provided just recently by the folks at the ONC. And so without any further ado, I'm going to introduce Holly Ahrens, who's the Clinical IT Manager for HealthPOINT. And Holly's going to go through and provide the content. With as much content as there is to talk about today, there will be the opportunity to ask a few questions. But I think what we may end up doing is having a follow-up webinar to discuss just the questions that may arise, just based out of some of the feedback that has come up on some other calls. It might be good to offer that. So at the end of this presentation, when we typically, our survey just kind of pops up, we want to give the opportunity for everybody to type in as many questions as you like, and then we will put together a webinar based on those questions. So if we don't get to all of them today, fear not, we will schedule something in the next couple of weeks to get those covered. So just to let everybody know about that. So with that said, I'm going to turn this presentation over to Holly Ahrens.
All right, thank you. All right, thank you everyone for attending. Just hold the presentation here and we'll get started. Like Jeff said, we have quite a bit of content to get through today. So I'm not going to waste a lot of time in regards to introductions. I think most of you we've either met or you are aware of who I am. So I will go ahead and get started. This is the stage 2 notice of proposed rulemaking for meaningful use and also for certification of PHR technology. Now everything we're going to discuss today is proposed, so this is not final rule. This is all in the proposed rulemaking. So you're very much encouraged to comment. ONC and CMS is very interested in hearing what the provider community has to say about these proposed rules. The comment period opens on March 7th and will go through May 6th of 2012. You can electronically comment at www.regulations.gov, and also within the notice of proposed rulemaking there are the addresses where you can send comments as well, but the preferred method is through the electronic comment. Final rule is expected in the summer, this summer, probably in August. The documents that I'm going to be talking about today can be found at both of these links, the CMS rule, which is the meaningful use, and then ONC is the certification for electronic health record technology. The message that I'm bringing to you from ONC is that it's going to take time to benefit from meaningful use. This is, I think we all know this, that stage 1 really is that foundational portion of meaningful use. Stage 2, we are going to see more exchange and more coordination of care. So at that stage, you're going to see some more of those benefits. It takes a while to polish the stone. The NPRM is largely predictable. There's really no left turns from the Policy Commission that had made recommendations to CMS. ONC and CMS want you to know that they have listened during stage 1 to put out this proposed rule, and also they are listening now through the comment period. You will see that there are certain areas of big push. These were done to ensure that meaningful use continues on course. Some of those areas are going to be standards that are standard-based care coordination and health information exchange, more push on patient engagement, safety, and clinical decision support. Now, a lot of these pushes are tied to some national health goals, such as decreasing hospital readmission rates by 20% in 3 years, and also the Million Hearts program to save American hearts. Also, the patient-centered medical home. You'll see a lot of shared goals there. One of the major focuses, though, in government is really to decrease that regulatory burden and increased flexibility. So what's in the rule? There's going to be some minor changes to stage 1. It will show you stage 2 of meaningful use. There's new clinical quality measures, new measure reporting mechanisms, appeals, details on the payment adjustments, minor Medicare Advantage program changes, and Medicaid program changes. Today we're going to discuss the majority of these, but at a later date we will discuss appeals and payment adjustments. For the sake of time and the content that's available right now, I felt that those two areas probably could be left for maybe in a couple weeks. Also, Medicare Advantage doesn't relate to South Dakota that I'm aware of at this time, so we will do that when it becomes relative. So here are the new table of stages of meaningful use. You can see that the attesters of meaningful use in 2011 will have 3 years of stage 1, 2 years starting in 2014 of stage 2, and then starting in 2016 of stage 3. As you look further down the graph, you'll see that each stage now has 2 years. So 2 years of stage 1, 2 years of stage 2, and 2 years of stage 3, with the exception of those attesters in 2011. Now the to be determined areas, that allows for the possibility of a stage 4 of meaningful use. So what are the changes? In terms of requirements for providers and hospitals, in stage 1 on the left, you know that there was 15 core objectives and you had to select 5 of the 10 equaling 20 objectives. And now EPs, or eligible professionals, they still have 20 total, but there's 17 core and you'll be selecting 3 of 5 menu objectives. For hospitals, EHs or CAWs, previously you had 19 objectives, 14 core, and 5 of 10 menu. Now you will have 18. There are 16 core and 2 of 4 menu. Now it looks like there is change in numbers for the eligible hospitals and CAWs, but really they've consolidated some objectives and also removed some and added. So the concepts, there have been some changes within meaningful use. Exclusions will no longer count to meeting one of the one of the 5 menu objectives. Really, the reason for doing this is changing the focus from excluding yourself from a measure to really including. So they want people to not use that exclusion as a way to get out of using one of the objectives. Also, the denominators will include all patient encounters at outpatient locations for EPs that are equipped with certified EHR technology. Now, in no changes, that 50% of all the encounters for your volume is still in place, and also your measure compliance equals objective compliance. Now, there are some changes to stage 1. This is not just stage 2 that the NPRM is discussing, but also stage 1 as well. So we're going to just hit on the changes right now to stage 1, and then we will discuss stage 2. So I just want you to make sure you have that distinction in your mind. So for CPOE, in stage 1 previously, the denominator was unique patients with at least 1 medication in their med list. The alternate denominator now will be the number of orders during the EHR period. Now this is optional in 2013, so if you're doing stage 1 in 2013, you'll have a choice to use the old denominator or the new alternate. But if you're starting stage 1 in 2014, you will have to use the new denominator. Next is vital signs. Age limits. Age 2 for blood pressure and height and weight will now be age 3 for blood pressure, and there is no age limit for height and weight. Again, stage 1, 2013, this will be optional but required in 2014. The reason why they changed the age limit for blood pressure was to accommodate considerations to the pediatric community who had voiced concern about age 2, whether that was an appropriate age for blood pressures, and CMS agreed that age 3 would be appropriate. Next, and also in vital signs, there was an exclusion of all three elements if that was not relevant to the scope of practice. The exclusion now would be that allows the BP or the blood pressure to be separated from height and weight. So if height and weight was relevant to your practice and BP was not, you could use that exclusion. Again, optional in stage 1 of 2013, but required in 2014 going forward. Next is the test of your health information exchange. We previously in stage 1, one test of electronic transmission of key clinical information. That would now be removed, and you'll see when I go through the changes that a successful ongoing submission now will be the requirement in stage 2. So this is effective in 2013 for stage 1 attesters. E-copy and online access. The objective was to provide patients with an e-copy of health information upon request, and then also to provide an electronic access to health information. Now it would be providing patients the ability to view online, download, and transmit their health information. This will be stage 1 requirement for 2014 and going forward. For your public health objectives, your immunizations, reportable labs, and syndromic, there was some confusion in the verbiage that was attached to these objectives where they had the requirement by law. Now they've added the verbiage that except where prohibited to all three of these, and this will be effective in 2013. All right, now we're moving into the stage 2 core objectives. So as I said, wrap your mind around that we just talked about changes in stage 1 that are in the proposed rule, and you're able to comment on all of those. And now we're going to move into the stage 2 objectives. And these are the core objectives. You'll see there's not much change in terms of the titles, but there is some changes in thresholds, definitions, and verbiage. So we're going to go through each one of these. So, and this is going to be a table that will be provided on our website probably within the next few days. So I know it'll be feverishly writing things down now, but we will have this available to you, and we will let you know. So let's start through these. CPOE, this will be for EPs and EHs and cause. This will be using CPOE for medication. They've added laboratory and radiology orders. The verbiage is directly entered by any licensed healthcare professional. The threshold of the measure is more than 60% of medication, lab, and radiology orders created during the EHR reporting period are recorded using CPOE. Now, some of the language that is in here is the CPOE is to be the, quote, first order by a licensed professional. There are one of three ways to accomplish this. This would be the licensed professional personally using CPOE, a verbal order from the licensed professional to another authorized professional, or if there was an electronic or written order that was transcribed, that would then have to be destroyed, so the CPOE would act as the first order. Now, there is a request for comment on a couple of areas. One would be the definition of another licensed or unlicensed authorized professional. So if you have any regard to comment on that, they're asking that you do that. Next we have e-prescribing. This is for eligible professionals. You need to generate and transmit permissible prescriptions electronically. The threshold is more than 65%. Also in this measure, you have to compare that prescription to at least one drug formulary and transmit it electronically using certified EHR technology. Now, one of the requests for comment is in regards to controlled substances. I think we know that there was some change in the controlled substances that could be e-prescribed. They'd like to know if providers feel this would be a time to now include controlled substances, or do we need more work in terms of functionality capabilities in regards to e-prescribing controlled substances. So please make a comment on that if you feel strongly about that. I have a couple reminders for you. The e-prescribing incentive program through CMS sunsets in 2015, and in 2013, the calendar year, the MIPPA e-prescribing payment adjustment will be done as well. So in terms of those incentive programs overlapping into stage 2, those will be moot points. Next is demographics. This is required for both professionals and hospitals. You will require more than 80% of all unique patients have demographics reported as structured data. Vital signs, we kind of talked about some of those changes there. Again, displaying BMI, plot and growth, growth charts for patients 0 to 20 years old, that remains the same. The threshold now is more than 80%. Now the blood pressure for patients aged 3 and over only, and height, length, and weight for all ages needs to be recorded as structured data. Next is smoking status for patients 13 years and older. Threshold of the measurement is more than 80% of all unique patients 13 years or older have a smoking status recorded as structured data. Requests for comment at this objective as well. At this time, nationally, they indicate that they don't have a way to collect good data on secondhand smoke and as well as types of tobacco that are used. So if you're so inclined, you could comment on that. Our next objective is clinical decision support. There are 2 aspects of this measure. First, you need to implement 5 clinical decision support interventions related to 5 or more clinical quality measures at a relevant point of care for the entire EHR reporting period. They've consolidated 2 objectives here. The second part is that you've implemented the functionality for drug-to-drug and drug allergy interaction checks for the entire EHR reporting period. So this is one of those that they consolidated, the clinical decision support, and then also the drug-to-drug is considered a clinical decision support tool. Clinical lab test results as structured data. Your threshold is now more than 55% of all clinical lab test results, whether they are negative or positive or numerical format, are incorporated into the EHR as structured data. Generating lists of patients by specific condition for quality improvement, reduction of disparities, research and outreach. At least 1 report listing patients with a specific condition. Next is for EPs only, clinically relevant information to identify patients to receive reminders for preventative or follow-up care. You will need to have more than 10% of all unique patients who've had an office visit within the 24 months prior to the beginning of the EHR reporting period need to be sent a reminder, and this is by their preference. So in terms of workflow, this might be an area where you would like to comment to the ONC and CMS in regards to how that workflow would be accomplished, because the patient would be identifying their preference of that reminder. Next is for hospitals and cause, electronically track medications from order to administration through an electronic medication administration record. So you will need more than 10% of the medication orders created by authorized providers during that EHR period have to be tracked using electronic medication administration records. Next is view online, download, and transmit. Now the objective is for both professionals and hospitals. And the objective is to provide patients the ability to view online, download, and transmit their health information within 4 business days of information being available to the EP. And then for the hospitals, the wording is transmit that information, view online, download, and transmit about a hospital admission. Okay. Now, the threshold for EPs is that 50% of all unique patients during that reporting period are provided timely, which they identify as 4 business days after that information is available to the EP, for them to have online access to their health information subject to the EP's discretion. So if there is portions of the record that you would like to have withheld, you have that discretion to do so. Now, more than 10%, this is the second part of this for EPs, more than 10% of all the unique patients seen by the EP need to be able to view, download, or transmit to a third party their health information. So again, this is an area where you were asked to comment in regards to how that workflow would be done within a provider office, of how you would track the viewing, downloading, or transmitting to a third party of a patient's health information. The only change for the hospitals, again, they have to have the 50% of all patients discharged, have that available online within 36 hours of discharge. And then the second portion is, again, the 10% of all patients who are discharged be able to view, download, or transmit to a third party. Again, I encourage you to comment on that. The next is clinical summaries provided to patients for each office visit. This is for eligible professionals. This needs to be within 24 hours for more than 50% of your office visits. Using certified technology to identify patient-specific education. More than 10% of all office visits for EPs and more than 10% of unique patients admitted. Next is secure messaging for professionals only. A message needs to be sent using the electronic messaging function of the EHR for more than 10% of unique patients. And if you transition patients from one setting to another, for both EPs and hospitals, need to perform a medication reconciliation for more than 65% of the transitions of care. Next is transitioning care and providing a summary care record for transitions of care and referrals. This is both for EPs and hospitals. The EP or hospital that transition or refers their patient must provide a summary of care record for more than 65% of transitions of care. And then the second part of this measure is the same EP or eligible hospital that is transitioning, referring their patient, electronically transmits a summary of care record using certified EHR technology to a recipient with no organizational affiliation and using a different EHR technology vendor than the sender for more than 10% of the transition of cares and referrals. Now this is one that, again, I think you should comment. They've asked for people to help them with the definition of organizational affiliation, and I think in South Dakota that we would be able to provide a unique perspective in regards to our IDNs and also the affiliations that people have with their EHR vendor who may be a health system, and also that vendor definition. So please feel free to comment on that. The next is ongoing submissions to public health agencies. Now, in the past, you had to test the exchange for immunizations, reportable labs, or electronic syndromic surveillance. Now, the requirement for an EP is for the immunizations to submit an ongoing successful submission. And then for hospitals, they have to do all three. So the immunizations, labs, and syndromic. And these have to be successful, ongoing submissions. I would suggest that you comment also on this one to ensure that successful, ongoing are both defined to our specifications. The next is security and risk analysis. This is the last core objective. Again, you need to conduct a review, a security risk analysis in accordance with 45 CFR. Also, you need to address the encryption security of data at rest in accordance with requirements of 45 CFR. Again, you have to implement updates as necessary and correct any deficiencies. So this data at rest, I want to expand a little bit on this because this is new. This certification requirement is in regards to default encryption required only if data is stored on a device. Okay? The Office of Civil Rights, who administers the HIPAA regulations, is supporting this proposed certification. And the reason why is that due to the number of breaches that have been reported to HHS involving lost or stolen devices, the HIP Policy Committee really recommended specifically highlighting the importance of an entity's review of encryption practices and security risk analysis. So this is really a specific focus, and I think in a lot of organizations people have seen that more mobile devices are being used, and encryption really is something that should be addressed. There will be no changes to HIPAA regulations in regards to this, but like I said, OCR does support this. All right, let's move on to the menu objectives. There are fewer, but there is requirements to different for each P's and EHs as we had discussed. So first one is for hospitals, and that again is the advanced directive. More than 50% of all unique patients 65 years or older admitted to your hospitals have an indication of an advanced directive status recorded as structured data. All right. Next is imaging. This is a new objective. This is both for EHs and EPs. So imaging results and information are accessible through CHRT. More than 40% of all scans and tests whose result is an image ordered by the EP or provider at the hospital during the reporting period are accessible through CHRT. Again, this is one of those areas where I would recommend that you comment and on that accessible through CHRT. Those definitions need to be teased out, and when you look at how those processes are done, you would have to go through your EHR to view those images. A lot of people have separate software that is a image software. So again, I would suggest you comment on that. All right, the next is family history for both EPs and EHs. More than 20% of all unique patients have a structured data entry for one or more first-degree relatives. The next one for hospitals is generating, transmitting permissible discharge prescriptions electronically. So this is now a menu objective for hospitals. More than 10% of discharge medication orders for new or changed prescription are compared to at least one drug formulary and transmitted electronically. The next is a menu option for professionals, that is syndromic surveillance to public health agencies. And another new one for professionals, eligible professionals, is successful ongoing submission of cancer case information from EHR technology to cancer registry for the entire EHR reporting period. Again, that definition of successful ongoing submission. And then also, one of the things that I see as a move towards flexibility for our specialists also is the successful ongoing submission of a specific case information from EHR technology to specialized registry for the entire reporting period. So if you are a specialist, report certain information to a specialized registry, you could choose this menu option. Again, their focus is on inclusion versus excluding from objectives. All right, that was a lot of information. We aren't done yet. We're moving into clinical quality measures. There are some major changes from stage 1 to stage 2 in regards that the objective of submitting CQMs is no longer a core objective, but reporting clinical quality measures is still a requirement of meaningful use. The timing, there's been no real change in this. They've just kind of put it in a table format for CQMs. There's no change from stage 1 to stage 2. Again, the 90-day, then the full year, and you can see that. There's no changes there. The changes are in regards to how many clinical quality measures you will have to report. For eligible professionals, you had to do a total of 6. That was 3 core or 3 alternate core plus 3 menu. In stage 2, you'll have to do 12. They do give you options, though, and we're going to discuss these in detail. One is 12 clinical quality measures, 1 from each domain, 11 core and 1 menu, or PQRS group reporting. For hospitals, you had to do 15 in the past. You'll have to do 24. It's 24, 1 per domain. Now the CQMs are not going to change through 2013. They'll remain the same as they were published in the final rule in 2010. The specifications for electronic submission will be updated. Reporting methods, there will be different reporting methods, and that's one of those areas that isn't clearly defined. I have some information on that, but that's one of those things we'll probably have to discuss at a later date as we get more information from CMS and ONC. So reporting for EPs, like I said, there are options. For the EHR incentive program only, your option would be those 12 clinical quality measures, and you have to have at least 1 from each domain. Or you can do the 11 core and 1 menu, and through Medicaid it would be a e-submission, and also there would be an aggregate XML-based format for CMS submission. Now if you took the option of doing the EHR incentive program plus PQRS, because many providers do PQRS, this would be submit and satisfactorily report the CQMs under PQRS. So if you submitted a PQRS, you would get credit through the if you submitted through certified EHR technology, you would get credit for the EHR incentive program. This is a step towards aligning different initiatives with the South Dakota Foundation for Medical Care. They have the 10th scope of work going on right now, and there is certified electronic health record technology is defined within that scope of work, and this is where they are aligning these 2 programs, and it really is a step forward in regards to our program here at the Regional Extension Center and the QIO, Nancy Beaumont's program at the South Dakota Foundation of Medical Care. So we'll be working closely, and this option for stage 2 I think will be very beneficial for providers here in South Dakota, because you'll be submitting once and getting credit twice. So we'll be getting more information on this, and Nancy and I will have some information that will help you do both of those together. So beginning in 2014, that group reporting, you're going to have 3 options. And again, this is an area that we're still trying to define everything here. But if you have more than 2 EPs, each with a unique NPI under 1 tax ID number, you can submit 12 CQMs from the EP measures table, and it has to be at least 1 from each domain. Okay. So at EPs, they're in an ACO, which we will see more and more of these coming up by 2014. You will satisfy the requirements of the Medicare Shared Savings Program. If you're using certified EHR technology, that would be your reporting method there. And then for PQRS, again, you would satisfy that requirement in a group as well. Now for hospitals, again, you have 24 quality measures, at least one from each domain. Those are the 15 that you had in the final rule in 2010. They are having some consideration of instituting a case number threshold. This might be an area you want to research and possibly comment on. Again, reporting method is an aggregate, XML, CMS, and then possibly something similar to the EHR incentive program electronic reporting pilot. So again, like I said, these are completely defined at this point. We will have more information for you. Now there have been some changes to the Medicaid program, and so everyone understands there is a CMS Medicare EHR incentive program and a state level Medicaid EHR incentive program. So changes to Medicaid. They're proposing to expand the definition of a Medicaid encounter. There has been a lot of discussion about Medicaid encounter calculation. They're wanting to include any encounter with an individual receiving medical assistance under 1905B, including Medicaid expansion populations. Also to permit the inclusion of patients on panels. So if you have that focus of HMO, those panels, if they're seen within 24 months instead of 12, this opens up the patients that you could use. And then also permitting patient volume to be calculated from the most recent 12 months instead of the calendar year. So in your 90-day reporting period, you would look back in the most recent 12 months. Also, they're proposing to include any zero-pay Medicaid claims. So even if you did not receive a penny from Medicaid, even if they were covered by Medicaid, if they were a Medicaid recipient, you would still be able to include them even though you had no charges that were paid by Medicaid. So those are some proposed changes. I, again, encourage you to comment on these. ONC has said that they want good and bad comments. So if you have something good to say, it would be beneficial to comment. And if you have something bad to say that as well. So they are listening and want to hear everything. Some more changes, including addition of children's hospitals that don't have a CCN, and then extending states' flexibility within that definition. South Dakota did not go too far outside the lines of the definition of meaningful use for stage 1. So this was not something that I think South Dakota was pushing for, but Salam can probably give more information on that at the state Medicaid level. Okay, well, we got through the meaningful use portion of this. Now ONC has put forward notice of proposed rulemaking in regards to certification of EHR technology. Now some of the language is going to change. I know that when we came out to visit everyone, I know you probably heard us saying ONC ATCB certified is the version that you want. They're changing the verbiage to be either, now that A2B certification is now going to be called 2011 edition, and for stage 2 will be the 2014 edition. Okay, so that's the new wording you're going to hear, so try and adopt that to your vocabulary so we are all on the same page. They've included here just the rules that things were broken up into 3 different final portions of the final rule. They've now put them all under one under the NPRM. Now the certification coincides to the new objectives and meaningful use, so you'll see those here. I'm not going to spend a lot of time because we've already gone through each one of these. Then the revised certification, again, those that were revised or consolidated within the meaningful use objectives. And then things that remained unchanged in terms of certification, these were those. So why are they redefining CHRT? Well, it's important to provide greater flexibility. I think a lot of the pushback that they heard and felt from not only providers but also vendors was that anyone who had a specialty organization had to have 100% compliance in their EHR product with things that were outside of their real need in meaningful use. So this is going to provide greater flexibility, a clearer definition of CHRT and its requirements, and really promoting progress towards increased interoperability and, again, reducing that regulatory burden. In 2011 to 13, it was pretty much a 100% compliance. So your EHR basically was a big blob in terms of certification. It covered 100%. In the 2014, you're going to have a base EHR, and then the ring around, the first ring around will be all the core objective certification criteria, and then the last circle, kind of that bullseye, the last outer circle would be those menu objectives and the certification required if you're going to go into any type of menu objective. So the base EHR, this is going to be new terminology in the vendor community, so we need to understand what that will mean. Here's the certification criteria that will satisfy the definition of a base EHR. On the left are the capabilities, and then on the right you'll see the criteria and the regulation that it coincides with. So you're going to, in a base EHR, you'll be able to get patient demographics, clinical health information, histories, problem lists. Problem lists will be based on SNOMED versus ICD and SNOMED. Capacity to provide clinical decision support. Capacity to support physician order entry. Capture and query information relevant to healthcare quality, so that's your clinical quality measures. Exchanging electronic health information with and integrate some information from other sources, so there's where you're getting that transition of care, viewing and able to download and transmit to third parties, and then your confidentiality, hitting privacy and security. So building outward. So if they have a base EHR, this is the capabilities that we just talked about. So there will be products that are just base EHR products. Now for, if you're moving into the core objectives, you're going to have a technology that's certified for those core objectives and the measures for the stages of meaningful use that you seek to achieve, unless you're meeting an exclusion. Okay. Somewhat hard to comprehend at this point because we don't see this right now, but it's going to allow, if you bought a base EHR, let's say you're a chiropractor, you buy a base EHR or mental health, if everybody has a base EHR and then you purchase specialty software that goes with that, that matches your organization, then you can actually look at whether you need any type of meaningful use core or menus certification to go onto those other products. Again, this is one of those areas where it's not clearly defined at the ONC level. This is really proposed rulemaking, so comments are very much needed. And then again, the menu certification would be those capabilities for menu sets, objectives, and measures for the stage of meaningful use you seek to achieve. Now, initially in the 2011 edition, there was two ways you could meet certification: through a complete EHR or through a combination of different modules. Well, now you have three ways to get the 2014 certification. There could be a complete EHR, and then also you could have a combination of EHR modules, and also you could have a single EHR module. So you could actually buy that base EHR and have enough certification if you are just going for the, that base meaningful use. So for the reporting periods, for stage 1 in 11, 12, and 13, all EPs, SPAs, hospitals must have EHR technology that's been certified to the 2011 edition. We're going to have a gap here between 11 and 14. So if your product is certified to 14 within 11, 12, and 13, you can use the 2014 edition. Now when we move into 2014 stage 1 or stage 2, in 2014 you'll have to have the 2014 edition. Now previously the certifying bodies had been temporary. Those will now be moved into permanent certifying bodies, and the name change will be that this is an ONC HIT certification program. Now there's some revisions to the modular certification requirements. I've only put these up as reference. I am not going to delve into these. Again, this is a lot of information for 1 hour, and I'm sure most of you have gotten your fill after probably the first 20 minutes. I understand. So we have some additional links: healthit.gov, cms.gov, EHR incentive programs, and then the Office of Federal Register, where you can upload the NPRM. Now, we will take a few questions right now, but I want to just preface any questions that this is proposed rulemaking. So there is nothing final about anything that I've told you today. So the questions, the majority of them, you will probably use as comments, but we will entertain them today. And if I don't have the answer, I apologize. Again, this is strictly just proposed rulemaking, but I kind of would like to hear your thoughts on certain areas that we've asked in terms of comments. So I'm going to mute and let Jeff go ahead and take over from here. Figure out what I need.
All right, we'll give Holly a chance to take a big drink of water after all that information. But yeah, if you have any questions, go ahead and type those into the question area. And we've got about 10 minutes to go. If anybody wants to put a question out there. I do have one question. Let me make this a little larger so I can see. Could you repeat the lab incorporation and family history measurement thresholds, please?
Sure. Okay, for clinical lab results, needs to be more than 55% of all clinical lab tests that were ordered by an EP or authorized provider at the hospital, where these results were either in a positive, negative, or numeric format, must be incorporated into the EHR as structured data. And what was the second one, Jeff?
Second question, have you seen any provisions for ambulatory method 2 participation?
Provisions to ambulatory, oh, okay. Yeah, and this is where a lot of the discussion in regards to defining the patient volume and the encounters, there's a lot of discussion in regards to that, both at the AMA level, there is at the ONC level. That has not been worked out at this time. And I think I know where that question is coming from. So it's something that I have on my radar and waiting to hear where that conversation is going to go. So I will keep you updated on that.
And the next question is, will the hospital objects be based on 21/23 inpatients or ER, or will this be expanded to other areas, i.e. outpatients?
It remains the POS 21 and 23 in EDs.
Okay. All right. Any other questions? We still have a little bit more time to take a few more questions. Otherwise, for those who maybe want to sit and think about this a little bit, we will be able to field these questions through the survey following the webinar, and okay, here's another question. I'm concerned regarding out-of-track decision support that is obtained outside the EHR, such as consulting, UpToDate, or PubMed. Also, the registry functions of many EHRs aren't as robust as freestanding registries. What impact does that have?
Well, and this is purely just opinion from me that being that these are proposed functionality that we're going to be requiring of EHR vendors, the product that you have now is not going to be the product that you're going to have in 2014. So one of the reasons why the ONC extended stage 2 or stage 1 to allow stage 2 to start in 2014 was the consideration that functionality did not meet the objectives of stage 2. So I understand registry functions exactly. There are problems with them, and there's a lot of outside software, different types of decision support that are outside the certified EHR technology. One of the things that they are making a little easier for us as providers and organizations is that you don't have to have every piece of technology certified. Anything that is brought into the certified EHR can then be considered certified. So that's a little help there, but I completely understand that the functionality does not meet the same requirements of stage 2 as of today. Yeah, I think I missed your family history question. I apologize for that. Let me go back to it. And I have to find my place, so I apologize.
So the question I was looking up is, could we hear the family history threshold again as well? Holly has a thick book of about 600 pages that she's rifling through right now, so apologize for the delay.
Jeff, can you get the name of that person and I will send that to them.
So we'll answer that offline.
Oh, found it. Sorry. More than 20% of all unique patients seen by the EP or admitted to the hospital during the reporting period have structured data entry for one or more first-degree relatives. So that's more than 20% of all unique patients.
Okay, great. Okay, next question. Providing patient electronic copy of health record and being available online, will the patient have to request this information, or will it just have to be available for all patients?
It has to be available. What you're going to have to be tracking is whether you have to have that more than 10%, whether they viewed it, downloaded it, or transmitted it to another third party. So that's where I think the trick and workflow will be to be able to track that in some type of audit log to see if your patients are accessing that, if you make it available.
All right. All right. Well, thanks again, everybody, for attending.